Welcome back to the symposium. We are now going to begin the next session, which is going to focus on pancreatic cancer. I want to introduce the moderator for the session, Dr. Ahlawat. In the interest of time, I wanted to reference his bio in the brochure. But Dr. Ahlawat is a very accomplished gastroenterologist who has published a lot of manuscripts on all aspects of GI, colon cancer, advanced endoscopy, pancreatic cancer, and related topics. He's a full professor of medicine at SUNY Downstate Health Sciences University. He's also the chief of the GI division at SUNY Downstate. So please join me in welcoming him to the podium to introduce the speakers for the session.
Thank you, Dr. Salifu, for the kind introduction. And good morning and welcome to the session on the pancreatic cancer. We have 3 speakers for this session, and they will take the questions at the end of the session. First of all, I'd like to introduce the first speaker, Dr. Daniel King. Dr. King is the gastrointestinal medical oncologist and researcher specializing in pancreatic cancer, and he's assistant professor of medicine at the Zucker School of Medicine in Northwell Health in New Hyde Park, New York. Dr. King, please.
Thank you so much. Super excited to be here. What I'd like to do today is tell you about 2 stories that I've seen in the last 2 or 3 years that I've been an oncologist within Northwell Health. They are stories of the care that we provide to our patients, how we can do a better job, and how we've tried to help improve that care, primarily for patients that are vulnerable, from vulnerable populations. And so the 2 stories are going to be about germline testing. I'll tell you a little bit about what that is, and how we try to find patients with pancreas cancer and navigate them to care. So these are stories of pancreatic cancer, patients with pancreatic cancer within our network. So first of all, germline testing. What is the germline? These are the mutations that we inherit, and all of us inherit mutations, but it turns out that some of the mutations that we inherit may predispose us to getting various types of cancers. And so what I'm going to spend some time today is talking about what the meaning is of these mutations that we inherit, our efforts within Northwell Health to study whether these mutations are present in our populations and any disparities in our ability to detect them, what we did to try to improve our care of patients and the testing of germlines, and then what results we found over the last year having done so. All right, so first of all, in pancreatic cancer, patients should be tested for inherited predisposition mutations. Every patient with pancreatic cancer, that is now national guidelines. And so every single person should be tested for these germline mutations to see if there's anything they may have inherited that made it more likely to get cancer. That's important because it has implications, let's say, for their family members who could undergo screening to try to prevent pancreas cancer. It's also important because many of these mutations sensitize tumors to certain types of treatments. So if we can learn what these mutations are, we can treat our patients better. Normally, traditionally, how is germline testing done? It's done because medical oncologists see these patients in clinic, surgical oncologists see these patients in clinic, and we traditionally were not doing the testing. We were referring patients to medical geneticists who were then describing the risks and the benefits of doing such testing and then conducting the testing. Unfortunately, the rates of testing have been very low historically. Only about 1/3 of patients historically have been getting germline testing in the last couple of years. And we had some reports that our testing rates in our institution were seemingly low. And so we tried to look to see how we could improve this. So there's really 3 parts to what we did. First, we studied what was happening in our institution already. We conducted an analysis up through 2022 where we asked, let's gather everyone that we know of who had pancreatic cancer at our institution, and let's look in their records, let's ask our germline testing companies to give us who had testing, what were their results, and what fraction of our population is getting testing. We also looked to see by various demographic or socioeconomic factors whether that testing was different in any population groups in our institute. And then, as I'll get to later in the talk, we had an intervention, and then we tried to improve their rates. All right, so these are the results of us having mined our data up through 2022. We found several hundred patients that we had taken care of with pancreatic ductal adenocarcinoma. That's the main form of pancreatic cancer. And of that population, only about 40% of those patients had any documented evidence that they had germline testing. We also looked to see who was having testing by various groupings of people: sex, race, ethnicity, income. And it turned out that actually the uptake of testing didn't seem to differ that much by population group. On the other hand, the testing rate was only about 41%, so essentially no group had sufficient testing. We knew that we had a problem. We needed to improve our testing rates. So we started looking a little bit more about who was getting testing, how long it took to get testing, and what we uncovered was something that we had not expected, which is it took a while to get testing. So patients are getting tested almost a month after they're being diagnosed, and in part that's probably because they were not getting tested by oncologists at the point of care. They were getting sent to medical geneticists who then ultimately were doing the testing. And so actually a small fraction of patients were getting testing quickly, which means that the results were really not available by the time we started our treatments. And so we started asking, did the expediency of testing vary? And as we started looking into that, we recognized that there actually were some disparities in how long it took to get testing by various groups. So if we combine patients who are both African American or either African American or Hispanic as self-declared race and ethnicity, it did seem that actually it took longer on average to get testing done for underserved minority groups, significantly longer, by about twice as long. We also asked, what about just comparing simply African American patients to white folks? And that's where this difference was most prominent. This was the most significant finding that we found, is that there was a delay in germline testing being done for our African American patients. Whereas for Hispanic patients, it did not seem to vary quite as much. We also had smaller numbers, but it seemed like there were really a signal here that we needed to look into. The other thing is we just asked, okay, it may not be necessarily the fact that someone is African American. Are there factors that are associating with race that may explain or underlie the reasons why there are delays in some testing? And so we started looking at some other factors. By doing chart review, we asked, what about patients who need social workers to help them with some aspect of their care, some health-related social need? And what we found there, again, was striking, that the patients who had documented social worker needs, such as, let's say, transportation, were much more likely to have delays in testing by a substantial margin. We also asked by income. Does income have a factor? Does the likelihood, or does the likelihood that one is going to have a delayed test change with that person's median income? And that also was significant. And we also have a social vulnerability index, which is sort of a composite measure of many different factors based on someone's zip code. And we also showed that there was a disparity here too. So we uncovered that the delay in getting germline testing was associated with several health-related social needs and self-declared race. And so we knew we had a problem, and so we spent 6 months trying to figure out how to improve this. We got together with our Department of Medical Geneticists, and we presented to them our data and asked what are some things that we could try to do to mitigate these problems. And one of the things that the Medical Genetics Office had already been working on was a strategy with ovarian cancer doctors to have those doctors do testing at point of care by those doctors for those patients at those clinics. And so we rolled out the same thing within our group and promoted this intervention using our Pancreas Cancer Tumor Board, and we contacted every doctor that takes care of patients with pancreas cancer and said, starting from now, you guys can do the germline testing on your patients. This is how you do it. Let's start doing it together this way so we can overcome the disparity that we observed. And so that was the intervention, and then we measured how well we did. And we measured how well we did in the year 2022. And so that's what I'm going to show now. And essentially, what we had shown is over the course of about a year in which we had instituted a new way of doing germline testing. We now had 100 patients that underwent that testing, and the median delay was halved. Instead of testing over 27 days, on average, it took about 15 days, which, not surprisingly, was due to the fact that patients were now being tested by their original doctors, their medical doctors, rather than needing a referral. And we found that the delays in testing were significantly different from prior. We also showed that the differences which we had uncovered, which were significant between the underserved and non-underserved populations, they disappeared. So we no longer had a disparity in how long it took to get germline testing done, regardless of someone's self-declared race and ethnicity, and also, importantly, the social worker needs significance disappeared. So there's no longer a difference in how long it took to get germline testing done, regardless of whether someone needed social work done. Now, one thing that we were dismayed about, though, still, is evidently it still seemed like we were having too many people not getting tested in general. So I want to walk into that a little bit, because we spent a lot of time in the last 6 months really thinking about this question. We seem to improve the equity of care, and there were no longer differences based on socioeconomic or demographic factors, but it still seemed like there were a lot of patients who were not getting testing done. And so we started looking into why this happened. And so over the last year, we started looking at this in detail. There are 315 patients that we found with recently diagnosed pancreas cancer, and a lot of them we seemed to find no evidence that germline testing was done. So we started looking into why that was. And it turned out that quite a few of these patients were being taken care of by providers that were outside of our institute. And so they were coming to us as second opinions. It could simply be that many of these patients were getting testing done. It just was not documented in our electronic medical record. And so we falsely may have concluded that some of these patients were not getting done. And then here, let me tell you about the patients who were actually getting their care done by a Northwell oncologist. So these are patients who we would think should certainly have germline testing done. And so we looked at these patients, and still there were a substantial proportion, about 50% of patients who seemed, 50% of the 122, who we could not find any documented evidence that germline testing was asked for the population. So we still have a long way to go. We need to understand why it was that our own doctors at certain times were not offering germline testing to patients, so that next year when I maybe have the opportunity to present research again, we can tackle this problem and we can prevent anyone leaving our clinic from not getting germline testing done. So still some work to do, but we made some impact, but still some work to do. All right, now I'm going to shift gears a little bit to something that is different from germline testing entirely. It is an idea about how to make sure that everyone with newly suspected pancreas cancer has the opportunity to be seen in clinic, to be diagnosed, and get adequate follow-up care. Okay, so we're going to be talking about navigation and how we leverage some new AI tools to try to make this happen over the last year or two. I'm going to start by giving a little bit of background. As it was discussed earlier, African American patients with pancreas cancer have worse outcomes, and we're not really sure why that is. it is possible that some of that difference is driven by biological changes, maybe impacted by environmental factors. The New York Genome Center, Cold Spring Harbor, Downstate, Northwell Health, we are all very interested in this, and there's a study underway called the Polyethic 1000 study, specifically to study this question by taking tissue from cancer tissue from African American patients and sending it for very high-resolution molecular testing, DNA testing, at Cold Spring Harbor and the New York Genome Center. And I'll tell you that when I joined about 2 years ago at my institution, what was very disappointing to me is we had this very exciting study, but we were having a lot of difficulty enrolling patients into this study. And I did not understand why that was happening. It seemed like such an incredible opportunity to have all these resources from the city, millions of dollars being available to do this testing so we could truly understand whether there's any biological basis. And as I looked into what was going on, what we started to realize is that the reason why we were not enrolling patients into this study is because we were not finding our patients before they underwent biopsy. And because this study required patients' tissue before they underwent biopsy to consent them. If we were not finding the patients, we couldn't consent them into the study. So we were losing the opportunity to get patients enrolled into the study. We're not finding them early enough. So it got us thinking a lot about how traditional healthcare delivery works, which ended up having bigger implications than just this study. It just forces you to realize that traditional healthcare delivery occurs in a long series of steps, right? Patients see oncologists, surgeons, and medical oncologists at the end, right? It takes many, many, many steps that happen in series for patients to get connected to care. And so we started thinking and built a tool called iNav that tries to find patients much, much earlier, actually at the time of their scan, to get patients connected to various means, such as seeing an oncologist, but also, for the context of this talk, getting them enrolled into a clinical study. So basically, how did we do this? There are existing means of analyzing text using computers. We call this natural language processing, and there are open source tools even published by Google to take a look at how to do this. What we did is we took one of those models and we retrained it. We trained it to understand radiology language, and then we trained it to look at reports containing and not containing pancreatic cancer. That took us maybe about a year, and we worked together as a team to do this and ultimately created a model that we tested. And 77% of the time, if it reports that there's a suspicious pancreas cancer, there truly is on our review. And it doesn't seem to miss many cases either. So we tested this, and it seemed like we had something to really find these patients. The source of this information are all the radiology reports that are getting published on a nightly basis at our healthcare institution. Northwell Health is big. There's 17,000 abdominal imaging tests done a month. Right, so we are looking, every single day we start looking at these things. But I'm going to tell you about what we found looking backwards in time using this tool, and then how we use this tool to try to influence our healthcare delivery in our institute. So the first thing I'm going to show you is a little bit of step one and step two. We identified reports, we reviewed those reports to make sure that they truly contain pancreas cancer, and then we just wanted to know what happened to those patients. So this is a retrospective study we conducted back on January 2023. We looked at everyone from January 2023 whose report seemed to indicate a new suspicion of pancreas cancer. So when we did that, we learned several things. First of all, we compared how well does this tool work to find out our patients with pancreas cancer compared to other means at our disposal through EMR reviews, such as looking at pathology and ICD-10 codes and cancer registry, and we were finding a lot more patients this way than by other means. The second thing is that we were doing a much better job finding these patients and then getting them on to studies, including that Polyethic 1000 study. So we essentially tripled the rate of enrollment into that study simply because we were finding patients early enough that we could route them to a GI doc, to further care and a coordinator, and get them enrolled. We also asked, does this approach help us improve the care that we're doing. So I'd mentioned back in January 2023 is when we looked back, when we were finding these patients. Starting in around June, we said, let's take this process and link it to a navigation team. And with a navigator, we're going to reach out to these patients and the providers who order those imaging tests, and we're going to do everything we can to get those patients connected to care as soon as possible. So that effort was underway, and we compared how we did before using the navigator to how we did in June, where a navigator did everything we could to grab these patients and pull them and connect them to care. And so what I'm showing here is a graph that's comparing 3 different care delivery metrics: biopsy, outpatient oncology visit, and treatment. And on the y-axis is the time from diagnosis to, well, actually, the time from when the scan reported we have someone suspicious to these quality metrics. And so what you can see is that in all of these 3 groups, there was movement toward shorter number of days between when these scans were found and when these metrics occurred. And the first 2 were significant, and the one on the right was trended just missed significance. But we seem to be making strides toward getting patients connected to various aspects of care much faster this way. We also are treating more patients. So if we compare what fraction of patients of the ones that we biopsy we ultimately treat, compared to how things were, where we were treating only about 50% of patients, now we're treating more like 3/4 of patients. So more patients seem to be getting treated as well. I'm going to give you one specific example that I think really highlights how, from a health equity perspective, this tool and our approach does everything it can to prevent anyone from getting left behind. So here's the case I want to present to you. This is a case that came through in our tool about 4 months ago. It was a 60-year-old man who had presented to one of the local emergency departments in Northwell Health. He came in with abdominal pain. It was starting to get worse and worse. And the thing I want to point out about this gentleman is he came in the middle of the night. He's a widow, lives alone, he's a construction worker, not many resources. CAT scan that was done at 2 o'clock in the morning showed, unfortunately, lesions, all over. So this is a CAT scan image of the patient's liver. And on the left side of it, you can see kind of a ball-like structure, which is a large metastasis. There's several metastases in this patient's liver. There's also a large spot in the pancreas, very suspicious for metastatic pancreas cancer. He was told, these are striking findings. We need to do a workup for you right away. We would like to transfer you to our larger hospital so we can do a further workup and a biopsy. And he wasn't ready for it. He actually signed out against medical advice. He said, I'm going to follow up with my primary care doctor and get this worked up. But lo and behold, we found this case, right? This was on a Friday. We found it on a Monday. We realized no appointment had been made. And so we did everything we could to try to get this guy connected to care. We reached out to him. We reached out to his primary care doctor. And he agreed to undergo a review by our tumor board. He agreed to come in and meet with our whole medical team. And sure enough, he agreed to biopsy, and he agreed to participate in one of our clinical trials that we had for first-line metastatic disease. And he's had a great result, actually. Following 2 months of therapy, his disease is already starting to shrink. He's had a 15 to 20% response so far, and he's continuing on trial. So this is a patient that clearly was at risk for getting lost to follow-up. He may never have come to see us. He might have come to see us weeks later where his disease had already progressed and no longer eligible for a trial. But because we were able to find him and do everything we could to bring him in, to pull him in, we were able to get him on trial, and he had a good outcome. So just wrapping up now, I think some of the lessons that these 2 projects have instilled in me from a health equity perspective is that there seem to be some approaches we can take that are not necessarily sophisticated, but streamline how we deliver healthcare to try to ensure that we are delivering healthcare equitably. So can we just make sure that everyone gets the testing done that they should. So reflex testing, right? So almost like a checkbox. Let's just make sure that before this person leaves your clinic on the first day, you do germline testing for them, right? If we had that approach, if every one of my medical oncologists did germline testing before a patient left the door, everyone's getting germline testing done. There's no risk that that person does not follow up, does not go to another appointment, right? Remove barriers, right? Sometimes it's hard for patients to travel. Maybe a patient doesn't have a car. Maybe they have a job where if they take off, they get fired, right? We have to be able to make things easy for patients, remove those barriers, remove additional appointments, extra visits, so that patients can get care. And I think as we've learned through our tool, if there's anything we could do to find patients early, find them early by specialist teams that really care about providing optimal care, then I think we can also make sure that every person, regardless of their healthcare needs, gets connected to care. So a lot of people that contributed to this work, a lot of medical students and coordinators. I will wrap up by just saying thank you for the opportunity. Thank you everyone for being here. I think this is such an important topic, and it's by coming together like this that we can promote it, we can work together. I am very interested in designing a trial for pancreas cancer. I would love to learn from you about how to ensure that we have equitable enrollment into that study. That is something that I really would like to learn. Please feel free to approach me, email me, because I want to learn from you. And thank you very much.
Thank you, Dr. King, for a very interesting talk. And our next speaker is Dr. Antonio Baines. Dr. Baines is a cancer pharmacologist interested in identifying and validating novel molecular targets in pancreatic cancer for potential therapeutic interventions. Dr. Baines is associate professor in the Department of Biological and Biomedical Sciences at North Carolina Central University in Durham, North Carolina. And he is presenting via Zoom. Dr. Baines, please.
Good morning. Can everybody hear me? Can everybody hear me? We good?
Yes.
Yes,
Yeah.
Nicole.
Perfect. Thank you. Thank you. Well, first of all, good morning, everybody. Want to thank the organizers of this, this very important health disparities symposium, Dr. Salafu and Dr. Mooney. I totally miss being there in person. This is my first time not being there in person, other than through COVID. And sorry for not being able to come, but thank you again for allowing me to be able to still talk to you all about this very important topic of pancreatic cancer. And so we'll go ahead and get started. But again, just want to thank the organizers for hosting this. This has been going on for 9 years, and it's definitely has been a success. So I'm happy to be a part of it. So let's get started. Today's topic is blocking multiple cell signaling pathways to target pancreatic cancer. As was mentioned, I'm associate professor here at NC Central University in Durham, North Carolina. I'm also adjunct associate professor in pharmacology and in toxicology at UNC Chapel Hill. So I'm sure many of you have heard of UNC Chapel Hill, but many of you may not have heard of NC Central. So just want to real quickly just give you a little introduction. So NC Central University is a historically Black university in Durham, North Carolina. Actually right down the street from Duke University, about maybe 8 to 10 minutes from Duke University. We have about 8,000 so students. We have a law school, professionals. We have a law school. We have various research institutes, as you see here, and one of our big focuses in terms of biomedical research is in health disparities research and health equity. And so that's one of the things that we do. And so in terms of health disparities research, one of those areas that we study and focus on is cancer, such as myself. So just a little introduction to NC Central, and if any of you ever down in Durham, North Carolina, please feel free to come and visit. There's no financial disclosures to mention today, and this is our outline that I'm going to cover for today. Basically, challenges of pancreatic cancer, 2, PIM kinase as a potential molecular drug target, and then 3, targeting PIM and PIM PI3K mTOR with inhibitors. So those are the three topics that we'll briefly cover today, hopefully. Okay. So just in case there's anybody in the audience that that don't remember their anatomy or forgot what a pancreas looks like, this is a picture of a pancreas. It's one of the organs in your GI tract, and and the pancreas is made up of different cells, and because it's made up of different cells, it can lend itself to developing different types of cancers in the pancreas. The pancreatic cancer that I study specifically is a cancer that arise from this pancreatic duct here. So this is the pancreatic duct. And so the cancers that arise in this green tube here, this pancreatic duct, are called ductal adenocarcinomas of the pancreas. And this is the most prevalent of all the different types of cancers you can develop in the pancreas. And unfortunately, very lethal, as we will discuss shortly. Also, just to make sure everybody is clear, the pancreas is a very important organ. It makes digestive juices that get dumped into the pancreatic duct, which goes into the small intestine to aid in digestion. And also, it makes various hormones such as insulin and glucagon, and those hormones help to control blood sugar levels. So, as you can imagine, if the pancreas is compromised by cancer, and that's definitely going to disrupt the health of that particular person. This is just a picture of showing how, if pancreatic cancer is allowed to progress, it can form metastases throughout different organs in your body, including the liver. The liver is one of the main organs that you find metastases, and as you can imagine, this is not good for the liver in terms of proper and normal functioning. So, unfortunately, this could be also very lethal as well. Black History Month just ended, but I believe Black history should be celebrated all the time, and so I just wanted to just put this on your radar. One civil rights icon who was definitely known for his fight for voting rights for everybody, especially African Americans, is our Honorable John Lewis, who unfortunately, I think a couple years ago, passed away from pancreatic cancer. As with him, many who unfortunately get diagnosed with pancreatic cancer suffer the same fate, usually because pancreatic cancer is usually found when it's already spread to either regional lymph nodes or distant sites, such as the liver. And as you can see here, the 5-year survival rate is very low when you do not catch pancreatic cancer early. And unfortunately, we usually don't catch it early because there's no tests to detect pancreatic cancer early. When I first got into the field of pancreatic cancer many years ago, as a postdoc, the survival rate was around 6%. The 5-year survival rate was about 6%. Now, over many years, over 10 to 15 years, is now just recently made it to 13%. So 13% of all patients, after 5 years survive with pancreatic cancer, which is great in terms of we seeing that progression from 6% many years ago to now 13%. It's doubled. However, it's still one of the lowest of all the cancers in terms of a low 5-year survival rate. So there's still a lot more work that needs to be done. And what's even more concerning is that it's believed that in 2030, that pancreatic cancer is going to go from being the third most common cause of cancer deaths right now to being the second common cause of cancer deaths. So it's going to surpass colon cancer, and in 2030, it's believed it's going to become the second. And nobody knows why. So again, we definitely have some work to do to try to get a handle on this. Chemotherapy is one of the main ways we treat pancreatic cancer, and these are just some of the various drugs that have been approved by the FDA, the Food and Drug Administration, to treat pancreatic cancer. One just recently made the list. This Nalirifox just made the list just recently in terms of being approved by the FDA. But this is a common list of chemotherapeutic drugs that are usually used to treat pancreatic cancer. However, even though these drugs, some of them, such as nab-paclitaxel, gemcitabine, or FOLFIRINOX, although they show some, additional months of survival compared to just gemcitabine, standard basic care of gemcitabine, another chemotherapeutic. Although these drugs seem to add some extra months to patients, which of course is always a good thing, we still have a long way to go because, as you can see, is only a few extra months that's being added, additional months being added, and at the end of the day, many of the patients succumb to the disease. So we still got a long way to go before we can claim success in treating pancreatic cancer. In addition to chemotherapy, there's folks like myself who are interested in looking at various molecular targets, trying to find what particular signaling pathway or protein or enzyme can we manipulate or modify that could potentially either cause increase in cells undergoing apoptosis, cancer cells undergoing apoptosis, or just stop growing altogether. So we still are in this fight of trying to find what molecular target should we be going after. RAS has been a common target that, for those of you that are in this area, RAS has been a very important target that folks have gone after for over 40 some years. RAS is a GTPase, is proto-oncogene. When it's mutated, it becomes oncogene. RAS is mutated in about 30 to 50% of many cancers, but in pancreatic cancer, almost all pancreatic cancers, about 90% of all ductal adenocarcinomas of the pancreas have a RAS mutation. So there's been a lot of focus over 40 some years to try to target RAS. And many people, including myself, have shown over the years that RAS is very important. It's a driver mutation. And to the point that when you try to inhibit it, in this case, we inhibited with shRNAs years ago, we were able to show that we were able to decrease growth and tumorigenicity of this particular pancreatic cancer cell targeting RAS until most recently, about almost 4 years ago, I guess, where we were now able to target a particular mutation in RAS, specifically in this case, K12C, G12C. And so this was a huge breakthrough after so many decades of blood, sweat, and tears. Unfortunately, in pancreatic cancer, only about, I think, 1% of all pancreatic cancers have a 12C mutation, so this doesn't work well against pancreatic cancer, except for those, maybe those 12C mutation patients. But companies are now, and researchers are now making specific mutations that you see, in pancreatic cancer, like 12V and 12D mutations, as well as making a pain. And talk about another molecular target that I've been basically studied, for my career in pancreatic cancer, and that's these PIM kinases. So, the human kinome is about 500 kinases out there, over 500 human kinases out there. And the one I want to bring to your attention, very briefly, is this family of kinases called PIM kinases. There's 3 members of that family, PIM 1, 2, and 3. They're very similar in structure and homology, especially PIM 1 and PIM 3. They're serine threonine kinases. They're downstream of the JAK-STAT pathway. They're involved in cytokine signaling. And they phosphorylate a number of substrates, as you see here, that's involved in many processes in the cell. Cell cycle, drug resistance, which is one that they're interested in, cell signaling, et cetera, et cetera. So again, PIM kinases are proto-oncogenes. They can be overexpressed, and when they overexpress, they to be constitutively active and can phosphorylate different cancers. Looking at these PIMs, these PIMs, and including pancreatic cancer, as you see here with this arrow. And one of the things that's been noticed is with this genomic analysis that with pancreatic cancer, the PIMs that they found basically had deep deletions, so they had deletions, and they had amplifications. And so they had these different they had alterations in their genome. And studies have shown that alterations in this genome unfortunately leads to a poor prognosis in terms of overall survival compared to those that don't have an altered PIM genome. And so we've done studies to show that PIMs are overexpressed in tumor versus normal. So we see it, in terms of tissue, we see more overexpression of PIM in the tumor tissue than normal pancreas tissue, and then we also see a good amount of expression of PIM1 in a variety of different human pancreatic cancer cell lines as well, as you see with this Western blot. We've also seen PIM3, overexpression as well. Immunohistochemistry, we see PIM1 and PIM3, expressed in these tissues. And I forgot to mention earlier, these PIMs were first found in hematological cancers, but over time they've found them in many solid tumors, including pancreatic cancer. We also have shown that when you inhibit PIMs, in this case we inhibited PIM3 in these cell lines, PANC1s and Miyapacas, and looked at and treated those cells with gemcitabine, again, the chemotherapy, basic standard chemotherapy drug used to treat pancreatic cancer. And when we look at the caspase-3 activity, which measures apoptosis, we see that over time, over time, but we see as you increase the dose of gemcitabine, you also increase the apoptosis as well. So basically, by inhibiting PIM3, we show that we can induce gemcitabine, we increase gemcitabine-induced apoptosis. So again, by inhibiting PIM3, we make the cells more sensitive to gemcitabine-induced apoptosis. You definitely see that here. You see the trend here with PANC1s, but you definitely see it more evident with Miyapacas. We also showed that when we use a PIM inhibitor, when we used SGI-1706, one of the first PIM inhibitors to make it through phase 1 clinical trials, we showed that when we combine the two, the PIM inhibitor with gemcitabine, we can get a synergistic decrease in cell viability when you combine the two drugs. So if we show that we inhibit, modify, manipulate PIMs, expression or activity, we can make the cells more sensitive to chemotherapy. Okay, and then in the last part of my talk, I want to talk about some recent research we've been doing as it relates to PIM kinases. So there are many pathways that are activated in cancer, including pancreatic cancer, and one of those pathways is the PI3 mTOR pathway is activated in cancers, which gives the cancer growth advantage compared to its neighboring normal cells. And drugs have been made, inhibitors, kinase inhibitors have been made against each of these different targets. So PI3K inhibitors, there's AKT inhibitors, there's mTOR inhibitors, and so and then even there's been dual, PI3K mTOR inhibitors. So they've been inhibitors either as single agents or as dual, agents, to try to combat the cancer. And so the question is, well, what if we make a triple inhibitor? So instead of going after two targets, like PI3K and mTOR, how about we maybe add another target, into the mix against PIM kinases as well? And so that was the focus of the research that we did in collaboration with investigators at UNC and also at Stony Brook. So we wanted to look at this novel and also a company as well that allowed us to use the inhibitor. And so we basically want to evaluate the use of this multi-kinase inhibitor that hit PIM kinases, PI3K, and mTOR all at the same time. And this name of this compound is called AUM302. And this came from the company AUM Biosciences. And so we compared it with a traditional commercial available PIM inhibitor called TP3654. And so this is just showing some data where we compared TP3654, and TP stands for Tolera Pharmaceuticals, And this is the second generation PIM inhibitor from the SGI 1776. So the SGI 1776, unfortunately, when it went through phase 1, it got kicked out because of potential cardio issues. And so the second generation is this TP3654. And then this IBL 202 is really AUM 202. It just initially started off, with IBL from Infectious Biosciences. And so if you just notice real quick, whereas, most of these concentrations for these, for TP and SGI are in micromolar ranges, this IBL, which we're going to call again AUM 202, is in nanomolar ranges. So it's much more potent. As you can see here, much more potent. Okay, so just again, real quickly, because I know we're running low on time. So here we show that basically that we are inhibiting the viability of multiple pancreatic cancer cells. And so just real quickly, the black is gemcitabine, this triangle going down, it's BEZ 235, which is a dual inhibitor. GDC 0841, also a dual inhibitor, and then we got TP 3654, and we got the AUM, which is an orange square. And then the green triangle is the AUM 302. And in most of these cell lines, you see that the green curve, which is the AUM 302, the triple inhibitor, PIM, PI3K, and mTOR, seems to work the best. So again, just showing that that viability is impacted by this triple inhibitor. Okay. We also wanted to look at proliferation of multiple pancreatic cancer cell lines, so BXPC3s, CAPAN2s, MIAPACA2s, and PANC1s. And I know you see a lot here, so you're probably saying, what in the world is this? No problem. We're just going to focus. We're just going to focus on what's most important. So I'm going to help you out with that. And so as you can see here, so basically we did different time points, 24, 48, and 72 hours. And we did, the first, so we did DMSO, which is just a regular control, and then we did TP 3654 at 2 concentrations, and then we did the AUM 302. That's why I meant 302, not 202, but 302 at different concentrations. And as you see in the square box I have here, that we see a decrease in proliferation with the AUM than with the TP compound. So if you just look at what's in the square box, you see it goes down compared to what's outside the box. To the left of it, and you see that there's a decrease. So just showing that the AUM 302 definitely seems to be working in terms of decreasing proliferation. Okay. Also looked at apoptosis. Again, the PI3, AKT, mTOR, all that involved with apoptosis as well. And so we show here that the AUM 302, this triple inhibitor, seems to also have an impact on sub-G1. So again, here you're looking at percentage of cells in different phases of the cell cycle. So sub-G1 is referring to apoptosis, G0, G1, and then S, and then G2M, again, either with the TP compound or with the AUM compound. And as you see in the box here, we're looking at apoptosis, and you can see an increase in apoptosis. See it going from left to right. It increases, and it's statistically significant, showing that sub-G1, which is indicated apoptosis, is going up when treated with the AUM inhibitor. We also, looked at some other cell lines, referring to cell cycle, and again, same format, sub-G1, G0, G1, S, and G2M, and just focus on what's in the square boxes. You see an increase of between TP to AUM, you see it goes up, suggesting that what's going on is that we're causing an increase in G0, G1, so cells are getting stuck in G0, G1, and cells are also potentially getting stuck in G2M as well when you treat with the AUM compound compared to the TP compound. Almost done. Well, so when you start looking at cell cycle, you start seeing changes, you may want to start looking at proteins that may be involved with those changes. And so, again, I know there's a lot of Western blot data here to look at, so I'm going to help you out by just have you focus. And so here we are looking at different substrates. So we're looking at different substrates of PIM PIM phosphorylates many different substrates, mTOR, and S6, so we're looking at, in AKT. And so as you can see here, we have different concentrations of TP compound and different concentrations of the AUM302 compound. And as you see more of a decrease with the AUM compound than with the TP compound. So you see that with phospho-AKT, you only see a difference in the with the AUM here, same thing with phospho-AKT, and same thing here. Compared to the TP, there's not really any difference, or a slight difference. We also look at S6, you see kind of the same thing, where you basically see more of a decrease in the expression of the phosphorylation components of these different parts of the pathway that PIM phosphorylates. So again, this triple inhibitor, where you're hitting PIMs, PIMs, hitting PI3K and hitting mTOR are having impacts downstream in different parts of the pathway that may explain the differences we see in growth and proliferation in the cell cycle. We also see that with mTOR as well. Remember, as an mTOR inhibitor, so we see a decrease as well, more so with the AUM than the TP compound. And then last figure I think I have is, we're looking at, again, cell viability of Mia-pockets that have been generated to be resistant against gemcitabine. So we've made pancreatic cancer cells resistant to gemcitabine. That's what the GEM-R stands for. So GEM-S, the cells are sensitive to gemcitabine, but GEM-R, those cells are resistant against gemcitabine. So, and that's what happens usually in pancreatic cancer. You treat with gemcitabine, and the cells become resistant over time to gemcitabine, and which again leads to challenges with the patient. And so, we wanted to test to see, well, what would this triple inhibitor, how would this help those cells that are resistant to gemcitabine? And so, just to help you focus, we're just going to look at the bottom, and basically we're looking at cell viability on the y-axis, and basically what we see here. And so we got DMSO, and then we have either the TP compound. So you see TP compounds. Okay, so at the top you see basically different concentrations of the TP compound, and then at the bottom you see with the AU compound. And basically we see, so for example right here, we see when we treat with the AU compound, we have less cell viability, when we treat the, in the resistant cell line. In the cell line that's resistant, we have, less than 100%, we have resistance, cell lines that are sensitive when we treat with the triple inhibitor. More so than, in a TP compound, you don't really see a difference until at the very high dose of 1 micromolar. With the resistant cell line, you see a decrease in cell viability. But with the AU compound, you start seeing differences at much lower doses, compared to the DMSO control. And then, you see, you definitely see it you see it at 1 micromolar, you see it at nanomolar, you see these decreases compared to the control. So again, showing that the AU compound is much more potent, and even with those resistant Mia-pockets cell lines than the sensitive cell lines. So in conclusion, this AUM302 compound, again, this triple inhibitor is a potent inhibitor of cell proliferation, cell viability, cell cycle progression, and phosphoprotein expression, while the TP3654 was less effective. So we saw some decreases with the TP compound, but not as much as we saw with the AUM302 compound. And then the AUM302 compound exhibits anti-tumor activity in human pancreatic cancer cells, and thus, may have a potential to be an effective drug for pancreatic cancer therapies. And then just to show you real quick, that the PIM kinase inhibitors, they are a real thing. This is just a list of some of the current ones that have been or currently in clinical trials now against various cancers. And so just want to, just show you that, the PIM inhibitors do seem to have a role to play as potential treatments in cancer. And so with that, again, this is a team effort. This is definitely not just me. Absolutely not. This was a team effort. So again, collaborators, at Stony Brook, Dr. Bilakowski's lab and others, and then, the company that provided the inhibitor, AUM Biosciences, as well as folks here at NC Central with me and at UNC. And so with that, thank you for your attention. I hope you were able to learn a few things about my interests in research in pancreatic cancer. and the need for more therapeutics, and I look forward to answering questions later. Thank you so much.
Thank you, Dr. Baines. We'll come back to you during the Q&A after the conclusion of the final talk. So the final speaker for this session is Dr. Pashtoon Kasi. Dr. Kasi is an oncologist and researcher at Weill Cornell Medicine and New York Presbyterian Hospital. He focuses on treating patients with GI cancers, and he's also associate professor of medicine at Weill Cornell Medicine. He's going to be talking to us via Zoom. Dr. Kasi, please go ahead.
Well, thanks so much for the kind opportunity. I had clinic today, so I couldn't come in person. Otherwise, would have been loved to be there physically attending the talk. So I was hoping to discuss again along the theme of disparities, one genomic medicine approach that could help reduce disparities and help increase access of precision medicine. Building upon some of the talks that you just heard, there's a lot of advances that are coming for patients, not just with pancreas cancer, I would say for all GI cancers and solid tumors in subsets of subsets, and we'll summarize and go over some of them again. You heard the different drugs for KRAS G12C, you heard different drugs for the PIM. There is all these different groups of diseases that fall under the bucket of pancreas cancer. So it's not just one disease anymore, especially with precision medicine and testing, but hopefully after the talk today, you'll realize how liquid biopsy can probably help reduce disparities at all phases of a journey of a patient with cancer. I'm a GI oncologist, as noted. I also oversee the liquid biopsy efforts within our Precision Medicine Institute. My email as well as social media handle is listed. Would love to continue the discussion today in the panel as well as afterwards. Here are my disclosures. They're also available on the website. We will be talking about some of the off-label use of some of these assays, and we have been on consultancy as well as advisory boards, given our expertise in the topic for some of these companies. So again, what I wanted to kind of build upon is, that this bucket of liquid biopsy that has taken the whole world of oncology by storm and is undergoing an exponential growth. It's not just one assay. So I'll help explain how this field is evolving and the types of liquid biopsies and even tests that are now available for screening. We actually just have a patient right now in the clinic who's undergoing a screening assay for pancreas cancer that is not necessarily the future. It's already something that's available in clinic. And then you'll see how this can be a tool that can help decrease disparities in patients with pancreas cancer and beyond. So at ASCO last year, that's our premier oncology conference, they called ctDNA the dawn of a new era, and that's truly what it is doing. There was a whole session devoted to ctDNA at our annual meeting, and that's true for all the upcoming major conferences. You type in the word ctDNA, there are hundreds of abstracts and presentations. So it's a tool that is increasing precision medicine and opportunities. And again, not to help replace tissue testing. I think that is a question that often gets asked. It's complementary and it's supposed to help fill the void. It's not meant to replace tissue testing. And if there is one disease where this is of extreme value, and I'll show you some data as well, pancreas cancer, often tissue genomic testing is not sufficient because the biopsy may be too small with an endoscopy, ERCP. Often pancreas cancer is has a lot of dense fibrous tissue or stroma, so you need amount of density of cancer cells to undergo some of this testing, which is not often feasible with even a good biopsy sample. So at least in a third of the cases, there might be an opportunity for ctDNA testing to help fill that void. Now again, the term broad liquid biopsy, it's not just circulating tumor DNA or ctDNA, but actual cells can be floating around in circulation. We've shown some work on this topic as well. And also, as one of my colleagues at Georgetown calls it, there's a lot of tumor trash that can be detected in the blood of the patient, some through active metastases, some through just apoptosis and necrosis that it can be detected in blood. And so it's not just ctDNA, it's RNA, it's cells, it's exosomes, there's proteins. You know, the basic tumor marker CA19-9 that we use for pancreatic cancer, colon cancer, as well as CEA, these are also, you know, in some ways, different types of liquid biopsies. So this concept is not entirely alien to us, but now we have so-called supercharged, you know, biomarkers that can be more useful, that are more sensitive and specific. And again, when you get some of these reports, you're not just getting information about mutations, you're also getting information about microsatellite instability. And again, you know, it's relatively rare in pancreas cancer, but for the ones where you find it, and we published a series and I'll show you some results, those are the patients that the word cure can be used with immunotherapy, which often, you know, even with the pancreas cancer being an unforgiving disease, despite surgery and mop-up chemo, there's still a fair proportion of patients who are not cured at 5 years, let alone the patients with metastatic disease. These are situations where you don't want to miss these home runs because these are patients who can be cured with just immunotherapy alone, and we'll show you some data on that topic. And then another biomarker that's also now being reported is something called TMB, or tumor mutation burden. And again, there's still work needed on harmonization, whether it's the same as blood TMB or it's the tissue TMB, but these cancers evolve and mutate over time, so liquid biopsy can help assess these changes to see if they would qualify for immunotherapy-based trials or approaches. And you know, an article just, or a plug-in in terms of it's not just for advanced metastatic disease. Liquid biopsy is moving up the ladder of phases of a journey of a patient with cancer. The biggest new topic has been this minimal residual disease detection. As the name suggests, this is kind of whatever cancer you're left behind with after you've done the curative surgery. But also, as I was telling you earlier, you know, for screening and early detection, I was surprised that there was a patient that I saw just a few months ago who got one of the screening multi-cancer assays at one of these wellness places that tell you to do exercise and keep your cholesterol in check and take whatever vitamins to prevent aging or whatnot. They're offering some of these tests already, so it's not, you know, it's again, whether or not who should be paying, how should it be done. Those are questions that still are being debated, but there's a bipartisan bill at Congress right now to get one of these multi-cancer early detection tests approved for all solid tumors. And I'll show you the performance of that assay for pancreas cancer. So with lack of tools to screen for pancreas cancer, at least in the high-risk population, this is one way of, again, picking up the cancer earlier so that we can, again, provide access to better care, curative care, and also, again, along the theme of reducing disparities. I'll share the slides. I just wanted to highlight some of the articles that are in GI cancers. Colorectal cancer has been the poster child, so you'll see a lot of data in colorectal cancer, but in pancreas cancer and solid tumors, we're seeing a similar trend of the challenges that you might see, the pros and cons of these approaches. You know, building upon Dr. Baines talk, you know, as you heard, pancreas cancer is not one disease. I guess the biggest subset that everybody now knows is the breast cancer related, or the BRCA or the BRCA family with the PALB2. And if you add these numbers, you know, it's anywhere from, you know, maybe 10 to 15% depending on which patient population. And in New York, you know, we have a big Ashkenazi Jewish patient population. So these numbers are a lot higher, and we, of course, have huge diversity. And it's not an uncommon issue of young onset pancreas cancer. So we're seeing a lot of these more often in terms of what they call HRD alterations, ATM. These are repair alterations. And again, we talked about MSI-high briefly. Immunotherapy is FDA approved, available. KRAS G12C, it's in the guidelines now. That's the newest kid in the block. And again, if you test everybody, you will find these patients. It's so, you know, with hundreds and thousands of patients getting diagnosed with pancreas cancer, I think that's what liquid biopsy provides. It provides completion of genomic testing. 2 of my patients right now with pancreas cancer that I have, again, on label, not off label, G12C inhibitors, one of them is called adagrasib. I don't have the proof of G12C on their tissue because their tissue was not sufficient for genomic testing, but I have a liquid biopsy that clearly said that they have G12C and they are on a drug that's benefiting them, whereas chemo would have stopped working. And again, chemo comes along with this bacterial toxicity. And there's another entity that's called KRAS wild type. You know, while KRAS is the hallmark for pancreas cancer, anywhere from 5 to 10% of the cases may not have this mutation. And this is the gold mine in terms of finding fusions and other aberrations. And again, tissue is considered the best in this scenario, but if you don't have tissue or tissue testing is not possible, in a third of the cases, liquid can help fill the void so that more patients can benefit from this approach. And again, the toolbox, this is just a simplistic cartoon showing that compared to traditional FOLFIRINOX and then some of these newer generation chemo with like nab-paclitaxel and lapasomarotcan, this got approval in first-line setting as well just a few weeks ago. But I think more so are the precision medicine-based approaches that are increasing in number as we get more targets and more agnostic approvals. BRAF just got agnostic approval, so every time I have to give this talk, I have to remind myself to add more drugs to this bucket. Again, individually they may seem like a small number, but if you add all these things up, they end up being anywhere from 20 to 25% of the cases. And there's a nice paper published in the Lancet recently where if you did find a genomic alteration and you acted upon it, again, precision medicine for the longest has failed because it's not just about testing, but it's about access to drugs. And with these approvals, access to drug is now possible, or through trials, that the survival was twice as much as opposed to the folks who didn't get genomically matched treatment. And especially with these genomic precision medicine therapies, these cancers evolve and mutate. So you can imagine if you have a patient right now who's been undergoing treatment for several years, the cancer that you have right now is not the same as it was a few years ago after all these treatments. So it's not safe, feasible, or practical to be biopsying patients again and again, or every 2 months, or every 3 months, the cadence. Whereas a simple non-invasive blood draw, CTD and liquid biopsy, you could do that easily. And again, building upon some of the previous talk, this wild type analyses that are one of several published, an array of fusions and aberrations are found in this not so uncommon bucket. And if you do find them, these are agnostic approvals like NTRK fusion. There are 2 TRK fusion drugs. There are, of course, BRAF inhibitors, the agnostic approval. There are NRG fusion drugs. There is, of course, drugs for ERBB2. So something to kind of keep in mind. And the only way you would find all these patients is if you are able to provide genomic testing to everybody, which is where I think liquid can help fill that void. This is a paper that we published last year. It was a national collaboration looking at all the patients who had MSI high. This is the best poster child for immunotherapy, identified on liquid, and then what happened to them. Again, we were able to find 12 patients and we had data for 9. Again, seems like a small number, but when it did work, these are the patients who are then alive years out. You see the flat line. You never see a flat line in patients with all-comer pancreas cancer. And several of these patients had already failed, several treatments had failed, and surgery was not possible. The cancer came back. So some of these patients actually went for surgery because they could still see stuff on the scans and all the cancer was dead. So when it does work, these are patients where it works really well, where even the role of surgery is being asked in some patients with colon cancer and other tumor types. And so similar is the story for pancreas cancer as well. If it's truly MSI high and the liquid data builds upon it, these patients benefit the same way. Not everybody, but more than 2/3 do benefit. And when they do benefit, these are the patients where the word cure is being used. Again, you heard Dr. Baines talk about G12C. This is some of the early readout. Every single patient, and some of these patients had 4, 5, 6 different types of treatments. So they were deriving benefit just from the pill alone, and now building upon the pill, they're adding another blocker to the highway with EGFR, which is even deepening the responses. There was an article just published in Nature Medicine a week ago looking at the addition of other G12C inhibitors to anti-EGFR. And right now, I at least know of 6 or 7, if not more, every time different companies who have come out with their own version of a G12C inhibitor, and which is relatively rare. I would say less than 1% in pancreas cancer. But the bigger bucket, which is KRAS G12D, there are 3 in trials from Mirati, Astellas, and then there's another company who has their G12D inhibitor already in trials. So again, it's not necessarily a distant future. These are trials that have already crossed the phase 1. And some of these trials are already available for patients here in New York across multiple institutions. And again, BRCA story is already known. We have a olaparib drug that's already approved. And again, it's not a small number when you combine germline testing with somatic testing, and also we pick up some of these secondary germline findings in liquid. I have a young guy who's has an appointment with me this afternoon. Again, we didn't have tissue that was sufficient for testing, and the liquid picked up the secondary germline finding, which is still not yet confirmed, but we already were able to get, platinum-based chemotherapy and now PARP inhibitor approved for the patient. So it is something that, is providing early access to help reduce disparities in access to care for these patients. And again, this is just the data for the POLO trial that led to the approval. There was crossover that was allowed, so that's why you don't see the OS advantage, but these patients live a lot longer than your average patient with with pancreas cancer. And this is also another drug that now is added to the guidelines called rucaparib. But again, you'll only identify these subsets if you know about them. Nobody has it written on their T-shirt that I have BRCA or I don't have BRCA. So testing is key, and liquid biopsy can help fill the void. And this is like a key summary slide. If there's one thing that you can take from my talk today, you'd be surprised how often testing fails. I would challenge you, ordering a test doesn't mean that it's done. Nothing against our pathologists or folks who are doing the biopsies. The harsh reality is whether it's an adequate sample or a sample elsewhere that you can't get access readily, there's delay that's involved, or even with a good sample, especially with pancreas cancer, there is scar tissue, a lot of fibrosis. That's why some of these chemotherapies don't also work as well as they work in some other cancers, which also leads to failures, and you can see a higher failure rate with pancreatic or biliary cancers because of all these reasons cited. So that's almost 1 in 3 patients. So again, not meant to replace tissue testing. It's not. It's head to head. If you had a good tissue sample versus liquid tissue, probably would be still the gold standard and will give you better information. But it's more about how often is it even complete. So when you add that number, it's complementary. Not in lieu of. And this is a great study that was done in Japan, which looked at over 5,000 patients. And you can see this is in a systematic setting in a well-established institute in Japan. Tissue testing versus liquid biopsy, it's almost, days versus weeks, and sometimes even longer. And that turnaround time, this is a paper from 2020. Now the turnaround time for liquid biopsy is less than 7 days, so which is remarkable. And you can see, again, this was all comers. The quantity was not sufficient 10% of the time, all GI tumors, but pancreas was like 20 to 30%. Whereas for liquid, unless you broke the sample or didn't collect the blood right, it's very hard to imagine why liquid biopsy would fail unless the cancer is not shedding enough DNA in the circulation. The other thing that the liquid biopsy has done is it's invented this new situation, which is a perfect ground for novel therapeutics. So it's called adjuvant plus, in my opinion, which means that whatever surgery, curative surgery, chemotherapy that you've done, and if you're still unfortunately not cured and you need something else, before it shows up on scans, there's anywhere from 6 to 9 to 12 months where you have an opportunity to do something more, because you've already done all the chemo, you can't get more chemo. You've already done all the surgery, and you can't see anything on the scans. So there's persistence of disease, so to speak, where you can pair novel drugs to it. And again, this is not an idea. This is already something in implementation. This is work with our group, with Sloan and other colleagues combined. This is first-in-kind KRAS vaccine with the focus in pancreas cancer. And this was presented at ASCO. It's an off-the-shelf KRAS vaccine that initially was targeting D and R, but now it's a 7-peptide vaccine that is targeting D, R, V, S, A, C. Pretty much it covers 80-90% of all your pancreas cancer patients. And what's different about this particular vaccine is it's tied to albumin, so it forces the peptide vaccine to go into the lymph nodes where all the immune cells are posted as a traffic signal, so to speak. So that's why they call it the lymph node targeted vaccine. So historically, people have been talking about vaccines for decades. Why has it not worked is because peptide vaccines get out of your system very quickly, whereas these vaccines stay in your system and get activated on the lymph nodes in a lot higher fashion, as shown here in this cartoon. But that's not the point I wanted to make about this trial. The reason why I want to present this study is we enroll patients in this trial based on ctDNA. So after you've had your whatever surgery, chemotherapy, or radiation in whatever order, if you're not yet cured based on ctDNA or biomarkers, you could enroll in this study. So this was a study that the FDA regulatory already approved that as an endpoint, where ctDNA clearance, you can see, in the fair majority of the patients, their own immune system was able to respond to the vaccine. Again, this was no chemo, no other immunotherapy drug added, just the vaccine on its own. So you can see clearance in about a third. And in some of these patients, the immune system gets activated a little later down the line. So we've seen initially like a rise and then later a dip as shown in some of the spider plot. But it's a great example of a trial that's challenging the dogma rather than waiting years for follow-up. As quickly as a few months into treatment, you can get a quick readout if your drug is working, not working. And already this trial has expanded. It's open, available right now at Cornell for any patient with pancreas cancer. Now it's undergoing regulatory approval, so everybody is eligible for pancreas cancer. Half of them get it right away, other half unfortunately have to be observed because right now there's nothing as standard of care, and they could always still cross over if they turn positive. So everybody gets the vaccine eventually. A trial that's available at Cornell. If there are patients, please do let us know. And again, for this trial as well, it wasn't just one kind of ctDNA. In fact, in 25% of the cases, the tumor-informed assay, where a piece of cancer is sent, they make a barcode for you, and you look for the same barcode in blood. That's the top cartoon, which is the tumor-informed assays. And then there are plasma-only assays where they just want the blood sample. So in this trial, it wasn't tied or married to one company. You could enroll in the trial regardless of which company's assay was positive. So the trial was smart enough to be more inclusive here, to allow everybody to participate. And this is what it's capturing. This is capturing cancer that's not still visible on the scans, because that's the limit of detection of what the scans can do. And it's capturing cancer whatever is not picked up by the scans. This also, in yellow shows patients who don't have cure, but still don't have anything on their scans, who could be candidates for more treatment. Along the same lines, before even, chemo or more chemo, us and our groups across other centers looked at, how does these tests perform in patients with stage 1, 2, 3, 4 pancreas cancer, because there is some question if the ctDNA is good enough in patients with pancreas cancer. And we were able to show numbers of ctDNA positive versus negative, and not surprisingly, they were higher the higher the stage. But more importantly, ctDNA on its own was the best predictor of outcomes, even stronger than stage, the sex of the person, or resectability, which are the traditional clinical parameters that we use. ctDNA on its own was the best predictor of outcomes. So it's a very powerful tool. Again, not meant to replace your staging and stuff. I always say, in fact, I'm somewhat opposed to these kind of analyses. While it does show that ctDNA is superior to all of the other information, I don't see why this has to be in a vacuum in a separate room. This could be taken into context. Whenever we see a patient, we of course take into their consideration their age, their sex, their race, their stage, the surgical issues, pathology report. I don't see a reason why ctDNA can't be a part of that toolbox as opposed to a separate question altogether. So but on its own, you can see ctDNA on its own can tell you about recurrence happening right away within a couple of years versus patients who are alive years out without the cancer coming back on just 1 or 2 post-op blood draws. So very early on, this can help stratify patients who may already be cured with your approach versus patients who may need something more. But something to keep in mind besides the assay, when do you need to make these decisions? That's usually in the immediate post-operative phase. That's when there is more background noise. So normal DNA from healing is also in the same tube of blood. So you could have a false negative. So you have to keep in mind it's not just the assay. You could have normal things going on in your background that may affect detection of ctDNA. But by repeating the assay at more than one time point, you can overcome this biological phenomenon. So essentially, you're looking for a needle in the haystack. There is a bigger haystack in the immediate post-operative period. So don't just rely. I think where the field of liquid biopsies right now is understanding that what a negative test result mean. It could mean that you're already cured, but it could also mean that you may have very little DNA, or there may not be enough shed. And then speaking of shedding, different cancers shed differently. Colorectal, again, is the poster child and sheds a lot of DNA. And shown here is pancreas cancer. Again, it sheds less, but it's not zero. So there are patients who shed, and it is something that maybe the current assays are not good enough, and there's more assays that are in development, but it's not like a black and white yes or no question. And each patient's DNA based on where their cancer is. So you can see, While it may not be 100% like for bladder cancer or colon cancer, but it's pretty high up in the 80s or 90s. Even sites of metastases matter. This is analyses looking at patients with similar cancers but different location where the cancer was. Liver is the lowest place of shed. So again, no matter how good the test is, if there's no DNA being spilled into the bloodstream, how are you going to pick it up? So you can't take the clinical context out of the equation as shown here in this cartoon. Depending on where the cancer is located, you may be able to detect less or more DNA. The other thing that's very cool is, it's a non-invasive blood draw. Can you use kinetics of serial testing to predict if something is working or not working? And the half-life, the beauty of ctDNA is only a few hours. So essentially, if somebody had surgery today, as early as DNA present. Now again, commercial companies and some of the trials, they want to wait a couple of weeks for the dust to settle before you order some of these tests. But if there is a drug that works really well across the board, our studies from other groups looking at plasma-only assays, tumor-informed assays, if you clear ctDNA, even in stage 4 setting, those are the patients who live the longest, even years out, versus if your DNA doesn't go down or for that matter rises or gets worse, that's an ominous signal. And early, this is a paper looking at, from the group at Sloan, looking at early clearance of KRAS, which is the most common mutation in pancreas cancer, and their impact on survival based on target therapy, chemotherapy. So this is something that could be used as an early biomarker as opposed to waiting for weeks and months or years for some of these bigger studies. Especially, it's very disheartening to see a study that was conducted for several years with hundreds of patients and then find out that unfortunately it did not work. In pancreas cancer, we've seen many large phase 3 trials be negative. Could this be an early readout that could spare hundreds of patients from being treated on a trial that may or may not be worthy of further investigation? Something to think about. Again, this is an editorial summarizing some of the topics we talked about. So where is the future directions? Again, going from metastatic setting to MRD, post-op setting, now we're getting down to early detection. So this is one of the multi-cancer early detection tools, something called MCEDs, that are commercially available. Right now it's not covered by insurance, but there's a bipartisan bill at Congress. There's a nice piece published in the Boston Globe that outlines the pros and cons of, would this test, some of these tests is like $950 or something. So that be done once a year? Who's going to pay for it? Even though it may not sound like a whole lot of money, but then if you're talking about hundreds and thousands of individuals, that's a lot of cost to society. So there's a lot of debate around the topic about screening and early detection. But again, this audience today, from a pancreas cancer and GI cancer standpoint, the methylation signals, so these are not picking up mutations typically, they're picking up some sort of a methylation signal, which not only tells you if you have cancer or no cancer, but then it's able to also predict with whatever percentage likelihood that 80% chance this is pancreas cancer, 40% chance is colon cancer, and then the clinician has to use their best judgment to try to find the cancer. But again, for certain cancers like thyroid cancer and prostate cancer, you can see the sensitivity is like 0. But for GI malignancies, you can see it's highly sensitive, which is something to that may help identify patients with pancreas cancer early, because if you look at the SEER data, national data, outcomes are strikingly different for stage 1 to 3 versus advanced or metastatic disease. And then it's not just about ctDNA, there's also CTCs. This is some of our patients with circulating tumor cells with GI cancers, including pancreas cancer, that are detectable. When you have the actual cells, it can give you more information about cell surface membrane that mutations may not provide. Again, going back to my first argument, ctDNA or liquid biopsy is not meant to replace tissue. CTCs are also not meant to replace ctDNA, but could be a complementary tool in that scenario. And there are multiple types and approaches of CTCs as well. This is just a small illustration showing one of the CTC platforms that we have available. Just like straining your coffee or tea, cancer cells that are large and less compressible than your regular white cells, this simplistic chip has these capillaries that forces the blood to go through this patented chip. And while the red cells go through, the larger cell, as you can see in this real-time animation, it captures the circulating tumor cells that is already on the slide that you can then, we're trying to see if we can grow it to do some of the experiments in real time, like, do drug testing, but you can also, use this as a slit and then stain it just from a simple blood draw. So again, these are things that are already something that innovations that are being done in the clinic and available, and these are some of the other platforms. With that, I'll stop and would look forward to the discussion. And again, thank you so much for the kind invitation.
Thank you, Dr. Kasi, for a very interesting presentation. With that, we come to the end of this session, but in the interest of time, we can take a couple of questions, if there are any questions.
Thank you. Hello, my name is Fatim. I have a question for Dr. King. I was wondering, are the endpoints from the times that you collected in the first part of your talk to the testing, if those are the days that the samples are collected, the day that the testing is done, the day that the results are coming out? Because I'm trying to understand where the delay comes post-intervention for that time. Like, why are there, does it take 2 weeks to get the patient testing done?
Yeah, sure. So in the two studies that I presented, in the germline data, we used the date of diagnosis to draw our baseline. For the AI approach, there the source was even earlier. That source is actually based on when the scan was done that the AI tool read. And so it allowed us to access patients earlier than before. We used the baseline of the scan showing a suspicious mass as the beginning of the clock. Yeah. The clock ends depending upon which outcome we're looking at. So for the germline test, the clock ended when the germline testing was done, the date that the blood was drawn to do the germline testing. For the AI tool, well, it really depends on what you want to look for in your health care delivery metric. So for example, is it the time that it takes between when something is found that's suspicious and they get biopsy? Then it was the biopsy date. Or what about how long does it take for that person to be seen by an oncologist? So it was a clinic date there. And then how long does it take to get the patient treated? I think as Dr. Kasi had mentioned, it's not only being able to order something, it's not only being able to see a doctor, it's also when does treatment start? Ultimately, it's the treatment that is going to affect someone's outcome. So in that case, how long does it take between when someone is found by imaging and then when the first treatment is, whether it's surgery, radiation, or chemotherapy, depending on the clinical context, time of treatment?
And just to add on that note, at least one thing that has helped, at least in the last year and a half, since the national NCCN guidelines endorsed universal testing for pancreas cancer and now also for colon cancer in the last 6 months, at least as an oncologist who sees these patients, we can order these blood tests, including liquid biopsies, including the germline testing, right away at the same blood draw. It also is convenient for the patient to be only poked once as opposed to getting testing and consultation. We still, of course, send the patient to our medical genetics colleagues for an official opinion and consultation, but more often than not, by being able to order the test without having to worry about insurance, since now it's embraced by the guidelines, the time it takes for us to find out the results, which then, after which we can act upon it to prescribe something, that time is now significantly reduced, which is helpful. In fact, I just as an anecdotal example, a couple of months ago, we had a patient, a young guy who was in a very bad situation in the hospital. Usually when patients get diagnosed in the hospital, there's always some crisis going on. And, they were already leaning towards, discussions regarding hospice and other stuff and were asking for our opinion. And our challenge was, we don't know if this is just the run-of-the-mill pancreas cancer versus somebody who may be harboring an aberration, especially with the age of being 40, so. And we didn't have, unfortunately, any history of family history and stuff. But then, long story short, we were able to send off the liquid and get the results back within 7 days. And lo and behold, it was a BRCA. And that person is outpatient, doing well on pills. Without testing, the harsh reality of pancreas cancer is half of the patients never even see an oncologist. They go straight to hospice. This is the United States of America. And another half don't even make it to second-line treatment. There's this treatment annihilation for pancreas cancer more so than any other cancer. So at least for the subsets where you may have a better drug besides just generic chemo, the first chemo for pancreas cancer was also approved because of improvement in quality of life. You will be able to help more patients if you can get access to testing quicker.
Dr. Khan.
So very nice session. So my question's for Dr. Kasi. So Dr. Kasi, so specific to pancreas cancer, I think ctDNA is excellent, it's an excellent tool and useful for the future. But how does it change your management of the patient? So the patient presents with pancreas cancer, had a Whipple, no radiographic evidence of recurrent disease 1 year out, and the ctDNA levels become elevated. Even for colon cancer, one can make that argument too. So, for pancreas cancer, there's less options, for the 63,000 people that are diagnosed, with the exception of, like you had said during the session, BRCA, and for the MSI patients. But I'm just curious, how it would change your management and how you address it, and if it's elevated, how do you deal with the patient's anxiety with an elevated ctDNA? Thank you.
That's a great question. And one thing about that last comment about the anxiety part, we actually presented patient-reported outcomes of patients undergoing ctDNA testing. And what was interesting was, as opposed to the argument that it increases anxiety, it's not a black and white statement, we looked at fear, recurrence, anxiety, depression, utility, confidence, trust. So even though it may not be the answer that you wanted to know, as long as the patient understands what we're going to do with the results, more patients valued that information and had more trust and confidence in the treatment that they were receiving. So I think there is, again, there are some patients who don't even want testing. So I think it's one of those discussions that I have with the patients and with colleagues. We often say, it's like for any test, it's important to know what you're going to do with the results. Your question, if it comes back positive or negative. For us, I would say we're somewhat lucky because we actually right now have at least 4 trials. I showed you that cartoon of this adjuvant plus. We have the KRAS vaccine that we can offer them. There's a Pfizer-BioNTech personalized vaccine trial that again is relying on ctDNA. And there are many companies that are looking at this unique patient data set and offering trials for those. Outside of trials, it's interesting. We've all been at these tumor boards where we do the CT, we do MRI, and there's like something indeterminate that, what do we do? It's kind of like, it's always 50-50. Sometimes we would do more testing or biopsy or whatever, or sometimes we would just do another scan in 3 months or 6 months. All that is arbitrary. In those situations, we've increased the cadence of scans, and often in the context of the right patient, when we have the ctDNA being positive, it's less easily brushed aside when it's the 19-9 that's fluctuating. So not the kind of information you would want to know, but I think it's been clinically helpful as, again, not to replace your decision making, but as an adjunct tool to help identify and confirm recurrences, especially for the tumor-informed assays. There's no possibility of a false positive. But it's these are kind of like what we do, but in terms of it's an active area of investigation and research that we need more trials to help support. Would that indeed affect outcomes in the long run?
With that,
I had a question for Dr. Baines. For the drugs that you're testing, have you initiated any in vivo studies with them?
That's a wonderful question, and actually yes. Actually, the AUM302, the triple inhibitor, I'm in collaboration with a colleague and friend, Amber, who works in Dave Tuveson's lab as a postdoc, and so she's currently testing that triple inhibitor on her pancreatic cancer organoids now. So I look forward to seeing if the data that we see in vitro will hold up in vivo. And as we know, that's not always a one-to-one all the time. But I'm looking forward to it. But yes, yeah. So we just start doing that, and looking forward to seeing what happens.
Me too.
With that, I think we're going to come to the end of this session. I'd like to thank all the speakers for their excellent talks and participants. So we'll reconvene at 1:30 after lunch. Thank you all.
Thank you.
Thank you.
Thanks.